Now we are going to have the third episode of Bexidoc Talk podcast about gestational diabetes mellitus. The episode is about the principles of general management of gestational diabetes mellitus during pregnancy. For this episode, we have with us Dr. Tanzim Sabina Chaudhry. She is working as the Associate Professor in the Department of Obstetrics and Gynecology at Burdem General Hospital 2 and Ibrahim Medical College. Madam, would you like to start with your topic?
Thank you, Dr. Naushaba. Thank you for your kind introduction. Today, the topic of my discussion is on the general principles of general management of diabetes in pregnancy. Now, let us start with what is gestational diabetes mellitus. Gestational diabetes mellitus is any form of glucose intolerance that is first recognized during pregnancy in an otherwise non-diabetic person. Now, even though GDM has been recognized for a long time, there has been still controversy regarding the screening method for the diagnosis of GDM. And as we all know that the screening of diabetes mellitus is the first step in the principle of the management of GDM. So, there are different criteria that is established by different associations in different countries. So, I will talk about the different criteria for diagnosis of GDM first. Let us start with the International Association of Diabetes and Pregnancy Study Group, which has recommended that we should do a 2-hour 75-gram glucose tolerance test in between 24 to 28 weeks of gestation, where the fasting level should be less than 5.1, 2 hours after 75-gram glucose less than 10, and 1 hour after 75-gram glucose less than 10, and 2 hours after 75-gram glucose less than 8.5 millimole per liter. We can also follow the American Diabetic Association guideline, which says that if we give 75-gram oral glucose tolerance test, the fasting should be less than 5.3, 1 hour after 75-gram glucose should be less than 10, and 2 hours after 75-gram glucose should be less than 8.6 millimole per liter. A lot of people also follow WHO recommendation for the screening of GDM, where the fasting should be less than 6.1 and the 2 hours after glucose should be less than 7.8. So, for the general management of GDM during pregnancy, it is very important that we follow a particular recommendation for early and proper screening of GDM, so that the management can be started as early as possible to reduce the fetal and maternal complications associated with GDM.
Madam, would you kindly tell us what are the commonly recommended method for control of hyperglycemia in pregnancy?
Thank you, Naushaba. Actually, if you talk about the principles of management of GDM during pregnancy, there are 3 options present. Number 1 is lifestyle modification. Lifestyle modification is an essential component of management of glycemic control during pregnancy. And second, we can say is if the lifestyle management does not work, the pharmacological management is by insulin. Third, there is oral hypoglycemic agent, which are rarely used for the management of blood sugar during pregnancy. So, the aim, whatever the method we use, the aim of glycemic control is that we have to make a patient euglycemic. That means we have to control the blood sugar level so that we can prevent the obstetric complications, and we have to find the optimum time and the appropriate mode of delivery for a woman with GDM.
Madam, can GDM be managed by diet and lifestyle modification?
Of course, Naushaba, because it has been seen in a study by the American Diabetic Association that about 70 to 85% of blood sugar can be controlled by lifestyle modification alone. And there has been a target which is set by the International Workshop Conference on Gestational Diabetes Mellitus that says that if the fasting blood sugar level remains less than 5.3 millimole per liter and the 1 hour postprandial less than 7.8 and 2 hours postprandial less than 6.7, it is considered as a good glycemic control. And as I said before, almost majority of the patient with GDM can be controlled by non-pharmacological method. For that, we have to counsel the patient about the importance of proper diet control, importance of regular blood sugar monitoring at home, and also most importantly identification and treatment of hypoglycemia.
Madam, please let us know what is medical nutrition therapy.
Medical nutrition therapy is a new term which is mostly used in United States, and the rest of the world is also known as nutrition therapy. Medicine nutrition therapy is a key component for the management of diabetes during pregnancy. It is defined as a nutrition based treatment which is provided by registered dietitian nutritionist. It includes a very important nutrition diagnosis as well as therapeutic and counseling service to treat diabetes during pregnancy. Now, there are different components in MNT. There is nutrition assessment, followed by nutrition diagnosis, nutrition interventions, nutrition monitoring, and evaluation of follow-up, and lastly, evaluation of outcome and modification of any intervention if needed. So, MTN, the food plan which is given in MNT is actually based on nutritional assessment, and there is a guidance from the Dietary Reference Index which is known as DRI. So, DRI of all pregnant women includes a minimum of about 175 gram of carbohydrate, a minimum of 71 gram of protein and 28 gram of fiber. That means these amount of food particles should be present in all women with GDM. And diet usually gives emphasis on monosaturated and unsaturated fat, and they limit the patient of saturated fat and trans fat.
Madam, would you let us know about the recommended nutritional breakdown of the diet that the GDM patient will have during her pregnancy?
Yes, actually the diet that is recommended for patient with GDM is not universal. It has to be individualized, and actually calculation of daily calorie intake will depend on lot of things like patient's age, her body weight, her gestational age, what is her physical activity. So, these all these things actually determine which would be her calorie intake. Approximately we say that there should be about 30 to 40 kcal per kg, or we can say an increment of about 300 kcal per day above the basal requirement for the patient for the pregnant patient during second and third trimester should be recommended for patient with GDM. And it has been seen that in a majority of patients with GDM, the optimum calorie intake is usually between 2000 to 2500 kcal per ml. And these total calorie intake has to be split. It has to be split into 3 meals and 1 to 3 snacks according to the patient's habit. And total calorie intake should be distributed according to different food groups in such a way that about 40 to 50% of calories should come from carbohydrate, and approximately 30 to 40% should come from fat, and the rest from protein. So, we can say that we have to actually divide the different components, and regarding carbohydrate, it is also very important that we divide the carbohydrate according to the need of the day. Like the amount of carbohydrate she has in her diet should be distributed to about 10 to 15% at breakfast, about 20 to 30% during lunch, and about 30 to 40% during dinner. So, that is how it should be divided.
Madam, kindly enlighten us about the benefits of medical nutrition therapy.
Well, the benefit of MNT is numerous. I mean, I cannot give more emphasis on the importance of general management, or we can say non-pharmacological management of GDM. It decreases the hospital admission of the patient for glycemic control. It decreases the need for insulin, which may be expensive for the patient. It actually reduces, it says that it actually helps promote the normal fetal weight gain, and also it makes the normal amniotic fluid, and also it overall reduces all the risks associated with abnormal glucose tolerance during pregnancy.
So, MNT, that is the medical nutrition therapy, has lots of benefits.
Definitely.
Madam, can you tell us what are the foods to be avoided for the control of blood sugar?
Yes, we have already talked about the food that needs to be taken in a woman with GDM, but there are certain foods that need to be avoided as well, like those food which are simple carbohydrates like potatoes, french fries, white rice, as we say in Bangla, bhat, chocolates, sweets, candies, and soft drinks. That has to be avoided because all these food causes rapid increase in the postprandial blood sugar. And we get to take a lot of processed food in our diet, that has to be avoided. Natural food has to be taken, and large amount of lean protein and non-starch vegetables and fruits have to be consumed more during pregnancy.
Madam, is there any role of exercise in reducing the blood sugar level, and if so, how?
That's a very good question, Noshaba, because it has been recommended that the patients having GDM can do both aerobic and resistance exercise in a moderate intensity. That means they can do it a minimum of 3 times a week, each episode lasting for 30 to 60 minutes. Now, if you ask me what is aerobic exercise and what is resistance exercise, aerobic exercise means large muscle activity in a rhythmic manner. It can be running, it can be walking, it can be swimming, even cycling. So, these should be done not less than 30 minutes as a stretch. On the other hand, resistance exercise like dumbbells and resistant bands can be used for as long as 60 minutes. Now, most of the women think that exercise is not recommended during pregnancy, but there is absolutely no contraindication for exercise during pregnancy in a woman with GDM. There are certain contraindications like medical contraindications which has to be followed, and in that case exercise should not be done. Otherwise, every woman with GDM can do exercise. And there are so many benefits of exercise, like it increases the amniotic fluid level and the plasma volume. It makes the woman more tolerant to labor pain, and there is also lower risk of preterm labor. And it has been seen that if a woman does exercise regularly, there is higher neurodevelopment of the fetus during pregnancy, and also there is a better intellectual capacity of the infant.
So, there are lots of benefits.
Lots of benefit of exercise during pregnancy.
Madam, would you let us know what are the challenges in the non-pharmacological management of gestational diabetes mellitus?
Yes, that's also very important, because being in a developing country, there are lots of superstitions and illiteracy around us. So, there are lots of social taboos, cultural habits, lack of awareness from the patient. And also there is a tendency of lack of adherence to the diet plan provided by the healthcare professional. And also there is an issue of screening cost and transportation to the nearest hospital. And we all know that in our families, most of us live in a joint family. So, everybody wants the best for the mother and the child. But as a result, everybody in the family has an opinion, and sometimes it can confuse and complicate the situation, and the woman cannot decide to follow the advice of the healthcare professional. And also there is a lack of information in the community as well, because of the social taboos and the cultural habits that has been going on for a long time. So, there are myths like exercise can harm the baby. There are myths that once you become pregnant, you have to eat double, and eat double means most of the cases eating more carbohydrate. As a result, because of this negative habit, it is very difficult for the healthcare professional to give instruction to the patient regarding the proper nutritional food and the need for exercise. Most of the women during pregnancy in our country take a lot of carbohydrate, and they actually take a very sedentary lifestyle. So, these are actually very much harmful for the management of GDM. So, these women should come forward, talk to the healthcare professionals about what they can have and what they cannot have, and about their regular daily exercise for the management of GDM.
So, as doctors, we should give emphasis on the non-pharmacological management
of course, and we have to make the patients aware about the benefit of non-pharmacological management.
Sir, would you like to share your valuable opinion regarding this episode, third episode?
The speaker has already talked about the screening for GDM during pregnancy, and this is extremely important, because if you do not screen this patient properly, you do not know who is actually suffering from GDM. And this screening should be done at a time when the patient is most likely to show the abnormality of glucose tolerance if she has got GDM. And she has explained it into details at the time and the procedure for proper screening. About the management side, We know diabetes is a disease which is not controlled only by pharmacological means. Lifestyle changes are also equally important, or sometimes maybe even more important. So, she has elaborated in details about the lifestyle management, particularly about exercise and nutritional intervention during GDM, and this should always be remembered as the first approach towards the control of GDM. And once the blood sugar level cannot be maintained even by adequate exercise and nutritional intervention, only then we should think about pharmacological means for controlling the GDM.
Now we are concluding the third episode, which was the principles of general management of gestational diabetes mellitus during pregnancy. Thank you, Dr. Tanzim Sabina Chaudhry, for enlightening us so elaborately and letting us know all the international guidelines regarding the screening and also sharing your experience. Thank you, madam. Podcast gives us the freedom to listen to what we want and when we want and how we want. Practitioners can tune in on their preferable time as their time is limited. In addition, multitasking and podcast can also go together, as podcasts are easy to listen to while practitioner is doing other things. Gestational diabetes mellitus is a very common concept and is easily understandable for all. As the global rate is going up in case of gestational diabetes mellitus, it is becoming one of the leading causes of maternal and neonatal morbidity and mortality. Listening to Bexidoc Talk podcast, Obs and Gynae, about gestational diabetes mellitus will gain a new perspective. With this hope, I am Dr. Naushabat Arnab Mahatab signing off.